Hello, everyone, and welcome to today's webinar called Patient-Centered Laboratory Medicine, Driving Improved Outcomes. My name is Colleen String, and I'll be moderating today's session on behalf of Abbott and in partnership with LabRoots. If you have any questions during the session or any technical difficulties, please type that into the Ask Question box and click Send. We will be reviewing all the questions and any troubleshooting during the presentation, and there will of course be time for more questions at the end of the presentation. It is now my privilege to introduce today's speaker, Paul Epner. Paul is the Chief Executive Officer and co-founder of the Society to Improve Diagnosis in Medicine. He is the chair of the Coalition to Improve Diagnosis, a member of the National Steering Committee for Patient Safety, which is a joint initiative of AHRQ and the Institute of Healthcare Improvement, and he recently became a member of the National Quality Forum's Leadership Consortium. Paul is a past president of the Clinical Laboratory Management Association and has previously collaborated with the CDC as a consultant to their laboratory medicine best practice program. Lastly, Paul is the associate editor for the peer-reviewed journal Diagnostic. Paul, welcome. The floor is yours.
Thank you, Colleen, and thank you to Abbott for this opportunity. I have no real disclosures other than the ones you have here and no conflicts of interest. So let's keep moving. Many of you may not have heard of the Society to Improve Diagnosis in Medicine. We are a 501c3 tax-exempt nonprofit that was formed in 2011. So not that long ago. This is our 10-year anniversary. Our vision is creating a world where no patients are harmed by diagnostic error. And the mission is really very fitting for today. We seek to catalyze and lead change to improve diagnosis and eliminate harm in partnership with patients, families, the healthcare community, and every interested stakeholder. So the three key elements of that mission statement are catalyzing. We know we can't do it all ourselves. The issue is too big. Leading change and doing it in partnership. And I appreciate the partnership today with Abbott and LabRoots in bringing this message to you. So let's start with something very basic. What is a diagnostic error? This definition was developed by the National Academy of Science, Engineering, and Medicine, previously known as the Institute of Medicine, IOM. It actually emerged from a report that SIDM, my organization, petitioned for. Many of you may know that the patient safety movement began probably in around 1999 with the publication of the report To Err is Human, in which the IOM published that 49 to 98,000 people die every year from medical errors in hospitals alone. Interestingly, that did start the whole patient safety movement, but diagnosis wasn't even mentioned. And so my organization in 2013 petitioned the IOM to do a report looking at diagnosis. And what emerged was this report, Improving Diagnosis in Healthcare, which was published in 2015 and is freely available to you all. If you want to read a 400+ page report, you can go to the National Academy Press, nap.edu, I think it is, and download your own personal PDF copy. They also have recommendations and an executive summary that can be downloaded as well. They identify diagnostic error as having three components: accuracy, timeliness, and communication. And in fact, we use the acronym ACT, SIDM does, for accurate, communicated, and timely in much of the work we do. So it's this failure, though, to establish an accurate and timely explanation of the problem or communicate that explanation to the patient. Now, diagnostic failures are a huge problem. They're frequent, they're harmful and costly. Here are just a few of the statistics. Hardeep Singh published a study that suggested 12 million adult Americans in outpatient settings alone experience a diagnostic error, with maybe as many as a third of them receiving meaningful harm from that. If the NORC, the National Opinion Research Center at the University of Chicago, surveyed a large number of patients who experienced medical errors and found that of those who experienced medical errors, 59% reported theirs was a delayed or wrong diagnosis. Gunderson, in a study he did, suggested that 100,000 people die prematurely each year from diagnostic failures in hospitals alone. So that's bigger than the original IOM problem. And what's interesting is the word prematurely. That's my word that I inserted, because many people with cancer, with sepsis, they might die anyway. But the diagnostic error led to that premature death, potentially totally avoidable, but even when it's not, it led to a premature death. And then financially, the estimates are that it exceeds $100 billion of negative impact to the U.S. economy. So big problem. If you look at the patient safety organizations that have published, one in particular, ECRI, that many of you may be familiar with, they publish every year a report on the top 10 patient safety concerns. In 2018, for the first time, diagnostic error became #1 on their list. That may have been the first time it was even on their list. And then 2019, it was #1 again. And in 2020, it was #1 again. So clearly the work of SIDM in building awareness was having an impact. SIDM also funded some research a couple of years ago. And in that research, the researchers at Johns Hopkins and CRICO, a captive risk management company that services the Harvard system, they looked at their database, which includes 26% of all malpractice claims in the United States. And so it's a large sample. And then they looked at only the serious malpractice claims. They used something called the NAIC, National Association of Insurance Commissioners rating system. And using just those ratings of 6 to 9, which equate to death and permanent disability, they found that that diagnostic errors were the most common, the most catastrophic, and the most costly of all the medical errors that were in that malpractice database. And if you look just within diagnostic errors, and the reason the previous page was called the Big Three, if you look just within the database of diagnostic errors, 74% of them fit within one of 3 categories: infection, such as sepsis; cancers, and the top one being lung cancer; and vascular events, such as stroke and MI. So a heavy concentration of diagnostic errors, the serious harm, is associated with those 3. Now, what causes this to happen? And so if you look at the contributing factors, you'll see, so first let me explain that for every malpractice claim, there were more than 3 contributing causes to each one. So the total certainly averaged more than can go up above 100%. But if you look across all of the claims, you'll find that 85% of them include some form of clinical judgment. So 85% of all of the claims that involve diagnostic error and serious harms involved clinical judgment. 35% of them involved communication issues, and 22% system issues. Clearly, clinical judgment is the big opportunity. And if you look within those claims, or within those contributing factors, you'll see laboratory, and not laboratory as the cause, but test results or test issues as the most frequent factor among all the factors. So failure or delay in ordering a test, failure to appreciate the results of a test, misinterpreting the findings of a test, patient not getting the results, There was either no report or a wrong report. Failure or delay in completing a diagnostic test that was ordered, or the clinician claiming they did not receive the test results. So clearly a number of problems, especially in that top category, that are very laboratory focused. If you look at other malpractice providers besides CRICO, you'll find that they too have noted that diagnostic error is typically the number one or number two category causing their malpractice claims. Covaris being just one of them did a special report. You can go to their website and download it. And they and CRICO and another malpractice company, Constellation, and the Doctors Company, they've all produced various reports which show similar results. And that is, again, and you can't really read it that well, but these yellow highlighted areas all reference a portion of the clinical process that have to do with testing. So this one has to do with ordering of tests, and this one, the fourth one down, has to do with interpretation of results. So over and over again, the test order and result management is considered to be an important source and therefore an important opportunity for improvement. Constellation, in their studies, I adopted one part. You don't see the first stage, which is the ordering of tests and taking of history and physical, but the results would be similar. Again, step number 7, tests interpreted, one of the biggest categories. Also, patient information communicated and follow-up are big ones as well. So I think all in all, everything I've shared with you so far says, 1, diagnostic error is a huge problem, a huge opportunity, and 2, laboratory tests, the laboratory ecosystem has a major impact and can have is a major opportunity for improvement. And if you just think about it for a second, it's somewhat intuitive. If you don't have an accurate and timely diagnosis, then everything that comes downstream, the treatment plans, maybe additional testing, et cetera, it could be all wasted. And so it's foundational to have an accurate explanation. It will inform everything that comes. I've written about that in an editorial that was posted in The Hill last March, where COVID further highlighted the importance of diagnostics. And what I came away with, and what I talk about a little bit in the article, it really illustrated the gaps in clinician knowledge. So the whole issue, and not just clinician, patients as well, the public, but the difference between virus and antigen and antibody, and the whole notion of detection windows and where are you in the course of a disease, and which factors can be measured at different times, which attributes. The whole notion of seroprevalence. I had a great discussion with my dentist who wanted to go buy a rapid test and have it and test every patient who came in the door. And I had to explain to him, based on knowing his population and where they were coming from, that he'd more likely get false positives than true positives. Issues of how to take the swab samples, the quality of the sample, and sampling errors. And then you get into interfering substances, demographics and comorbidities, and just the variation in quality. There were many manufacturers that were approved in those early days that had very low sensitivity and specificity, unlike the major manufacturers who really brought out very high quality products. But that really helped confuse the situation for many. I was part of a research study that was done now about 7 years ago, funded by the CDC, where we went out and talked to frontline clinicians about their comfort with ordering tests and interpreting results. And it really told us much of what we are seeing still today. When it comes to what to order, 14.7% of the time, clinicians reported that they were unsure of what step to take. When it came to what do the test results mean and what do I do with them, 8.3% of the time they were unsure what to do next and what it meant. So if you think of the billions of tests, these may not sound like high numbers, but if you think of the billions of tests, that is a huge result. Now, let me clarify, this was when diagnosis was the causation for ordering the test. So it was a patient coming to a clinician with a new complaint. If they were just being monitored for something that they already had been diagnosed with, then in those cases there were no issues, or maybe we didn't test for that. Let me be clear about that. But clearly, when it was a new complaint, a new symptom, and ordering was done for that purpose, that's where these problems prevailed. Let me just sum up the problem statement by saying that testing-related harm comes down to one of 5 things. It's either an inappropriate test has been ordered, an appropriate test has not been ordered, the result of an appropriate test has been misinterpreted and misapplied, an appropriate test is ordered, but a delay occurs somewhere in the total test, or the result of an appropriately ordered test is inaccurate. One of the things you will notice is that the lab really is only in control of the last item. We know that the clinical laboratory is among the most accurate and robust, reliable of all of the systems within healthcare. Anesthesiology and lab are the ones that are approximately or approach Six Sigma quality in general. And so that last category is the one that happens least frequently. But look at the other categories and consider the data that I previously provided, and you'll get some sense of what the opportunity is for lab to really go outside the walls and help. And it really does matter. I think we can all think of examples where a lab result was the cause of a problem. In this case, a very famous one that occurred in New York City. A gentleman, a boy, a 12-year-old named Rory Staunton, learned how to fly, wrote a letter to the North Korea president to tell him to change his ways. Just a very engaged young man who was playing basketball in junior high school and went diving for a basketball and scraped his elbow. And, you know, they gave him whatever first aid he needed at the time, as they thought. By that night, he was already starting to have symptoms. He was throwing up. He was having other kinds of symptoms. I'm not going to go through his whole story, except to say he had multiple visits to the emergency room, multiple visits to his primary care pediatrician. In the last visit to the emergency, or in the second to last visit to the emergency room, he was released home with a diagnosis of gastroenteritis. His vital signs, after the release papers were already signed, were starting to look ominous. And some test results, some hematology results, bands basically, came back just a little after he had been discharged, and no follow-up calls were made. Bottom line, within 3 days, this 12-year-old boy was dead of sepsis, of septic shock. So even if the lab does everything right, produces an accurate result, produces it in a timely fashion, accurately puts it in the LIS, accurately has it transmit it to the EHR, still a lab result can, or the absence of acting on a lab result can create a problem. So this all points to opportunities for the clinical lab to really make a difference. One is helping physicians with appropriate ordering. 2, ensuring timely and error-free processing. 3 is facilitating accurate interpretation. 4 is ensuring follow-up, that results are being acted upon. Overall, doing a monitoring of the process and engaging patients. We don't have time in this short talk to go through each of these categories. There are many opportunities in these categories. There are a variety of different publications available that can guide you through each of these, but I will go through a couple. Let me first say a lot will help if the lab considers where its priorities are. So I created this dichotomy of clinical effectiveness versus operational efficiency. And the truth of the matter is you don't pick one or the other. Every lab needs to blend both. But when you're focused on operational efficiency, you're really focused on reducing cost and systematic variation that can lead to errors. You really want a robust process. When you're focused on clinical effectiveness, you may be doing the same work, but now your North Star is patient outcomes. And your decision making is driven by the impact on patient outcomes. Unfortunately, the way labs are managed by health systems, as often as a cost center, we are so frequently pushed towards the operational efficiency side. And when in front of a live audience, I ask the question of where your lab belongs, the number of hands that go up for a heavy push to the operational efficiency side is overwhelming. Everyone wants to be focused on clinical effectiveness, but they aren't always able to. Let me clarify the difference in words. So an operationally focused clinical laboratory seeks to provide accurate, timely, and low-cost test results, which is great. In fact, that is absolutely necessary. It's just not sufficient. An effectiveness-focused clinical laboratory would also expand the definition to think in terms of rapidly and efficiently enabling an accurate diagnosis of conditions, enabling the selection of appropriate treatments, and enabling the effective monitoring of health status. I have often proposed that this should be the mission statement of the clinical laboratory. And so often the first bullet point is more typical. If you do all this, what you end up with is what Mike Hallworth and myself and others who worked on an IFCC committee called the patient-centered laboratory medicine. And that is what we achieve, strive for, with the true north being very, very clarified. The patient and system benefits are really easy to articulate. You end up with more accurate and timely and lower cost diagnosis, which is great. You end up with more effective treatments with less wasted expense, because clearly if you are dealing with the wrong diagnosis, it won't be as effective as if you're dealing with the right diagnosis. This will also lead to a more engaged and healthier population, especially with that strong patient engagement component. And your health systems will be more efficient and effective. So the business case is very easy to articulate. Let's turn to the solutions and how we actually can begin to make a difference. So the three categories. One is appropriateness of utilization, ordering the right tests. And again, you already probably are using tools like reflex testing, algorithms, clinical pathways, bundle order sets, various guidelines in order to try to help physicians come up with the right kind of utilization. There are other things. There's, of course, multidisciplinary utilization management committees. Again, we're going to jump into a couple in a second. The overall process robustness. FedEx, I always like to use FedEx as an example. They know exactly where a package is, if not every time, all the time, most of the times. And yet, for us, between when this order is placed and a sample is taken and the sample is transported and testing is done and the result is approved and released, and whether a physician opens it up, The physicians don't have visibility into every step along the way, and we aren't able to use triggers when things are late. So the whole notion of process robustness. I love to call out the one tests pending at discharge. With our fragmented system, we have hospitalists who order tests or emergency room doctors who order tests, and then the patient is discharged before even necessarily all the results are back. And there's been research that has shown clinically relevant test results come back, but no one acts on them because the patient's left. And there is that continuity to the next setting hasn't been adequately resolved. So that's another kind of an example where the system can break down, and the laboratory can get involved in trying to fix that. And then interpretation and action appropriate. We'll talk a little bit about interpretive comments and more data mining and patient activation, but there are many different tools out there that you can look at. I even list the EMR interface because so often when a laboratory receives an order, all they get is a medical record number and the analytes that are being ordered. But in many cases, they aren't getting much in the way of demographic information. They're not getting comorbidities, the problem list. They're not getting medications that the patient are on. Things that could all, are they on biotin? Is that going to create an interference that will affect the results? So that kind of data can be missing in the information that gets to the lab and limits the lab's ability to help the clinician interpret the results. Closing the loop on test results is a really major opportunity. I love this little cartoon, even though it's a little dated. It's a simple stress test. I do your blood work, send it to the lab, and never get back to you with the results. So it's so true. And in fact, many of the malpractice carriers saying closing the loop on test results is their first priority. It seems to them on the surface to be one of the simplest things to go after, and yet it's not. But many of them are working on that as an intervention and would welcome the lab's assistance in that. There are many resources out there. ECRI published this guide, which you can download from their site. We are partnering with the Malpractice Carrier Constellation. You can go to the SIDM website. There is a no-cost Closing the Loop QI collaborative that is recruiting right now and will be open for 9 more days, so you can apply by June 30th. And if it hasn't reached its maximum, you can participate with other organizations in going through a year-long process as a QI collaborative to try to resolve this issue. So there's one very concrete step you can choose to take, and you can see up there the link to the site. You can also just go to SIDM's website and find it there as well. Kaiser has done some interesting things with a process they call SureNets, and you can find that in the published literature. But they created a data mining regimen where they go in, and again, I recognize they have a closed system, so all their patients get their tests and care all within the same system, all within the same EHR environment. That also is probably true in most ACOs or heavily geographically concentrated areas. But they go in, and here's an example. They know that they require, per guideline, per their internal guidelines, that if there's an elevated creatinine, that there be a follow-up within 90 days. So the lab just queries the data warehouse and says how many lab orders or lab results have not emerged, the second lab results for someone with an elevated creatinine. In this particular time period, Kaiser found 5,324 follow-up tests that had not occurred. So they entered the orders in the system, the patients were contacted, and about 50% of them came in to have repeat results done. 50% of those still had abnormal results, and ultimately over 1,000 cases of chronic kidney disease that had been undiagnosed were identified. So here was a relatively simple approach to identifying a lack of a closed loop, lack of follow-up action, and an opportunity to really make a difference for patients. In another example, this had to do with therapeutic drug monitoring. And you can see, again, they were dealing with 117,000 missing orders. In other words, the patients were on a drug that required routine monitoring. And even after a certain period of time, a year or whatever it was, they looked to see were there results. And they found 117,000 where there weren't results. Ultimately, they ended up with 10,000 patients who were verified as having abnormal results. And as you all know, the only reason you do therapeutic drug monitoring is because it's important you be in the therapeutic window. And they found 10,000 where they weren't. Another SureNet that Kaiser does is around iron deficiency anemia and referrals for potential colonoscopies. In this case, as a result of work they did, they found 24 cancers that had not been diagnosed, that were not necessarily symptomatic in the typical way an advanced cancer might be. You can argue 24 isn't that many, but I think we would all agree 24 patients who may have survived what otherwise might not have been survivable is very important. And they did find disparities in there, but they did measure it and are pursuing it. And they have many such dashboards where they look at this kind of approach. The notion of interpretive comments was made for me, it was made famous by Mike Lipizzato many, many years ago, where he was inserting interpretive comments about coag results and could literally document many times where he helped avoid a diagnostic error. Now, you can't do interpretive comments, nor does it make sense to do interpretive comments on every single laboratory result. So Mario Plebani certainly tried to articulate criteria on when it should be done, and always was important, always emphasized, don't do cut and paste, because cut and paste get ignored. And so in this case, he also provided guidance about where one is most likely to see the value around interpretive comments. When Michael Lipizzato started doing it, there was no way to get reimbursement at all for the time the laboratory took, but that is changing. E&M, evaluation and management, is now a category that in the right circumstances, one can absolutely get some level of reimbursement for the work. Patient engagement is really an opportunity to make a difference. And I know Mike Astian has a long track record of inviting patients in the laboratory just to increase the sensitivity of lab professionals, but it's more than that. As we have a more fragmented healthcare system, where patients may see one doctor in the office, a different doctor in the emergency room, a different doctor in inpatient settings, a different doctor at ambulatory clinics, a different caregiver in the home. I mean, it's really becoming increasingly fragmented, and we know at the borders of setting changes, that's where communication issues really well up and other problems. The patients are the only common denominator, and they're highly motivated to make a difference on their care. Now, most of you probably know that CMS, the Center for Medicare and Medicaid Services, and ONC, the Office for the National Coordinator for Health IT, have recently introduced mandates around interoperability that went into effect in April. And they require the free and open access to test results and clinical notes. It's a step on the path towards making this data available to apps that a patient may choose to use as well. And yet we know that the read rate by patients of their test results and their clinical notes is very, very low. In the old days, of course, patients had to request test results. The labs had 30 days to produce them. It was a written report. Now all of that has gone away. So there's a real opportunity to start to build engagement with patients over becoming aware of tests and test results and watching for follow-up and making sure the patient has some understanding of the urgency of what they have to deal with. We all know the lab, in the clinical lab, is not where diagnosis occurs. It produces test results. But we have tools like lab tests online and other kinds of tools that we can use to initiate a broad engagement strategy and just try to get the patients to become more aware of their orders, more aware of pre-test instructions so that they do fast when they're supposed to, so they do tell you about those biotin supplements when they need to, etc. We want to make sure they're aware of that. We want to make sure that they look at their results and are aware of the follow-up requirements. So even if the lab doesn't get involved in making a diagnosis, still the lab can be a real enabler, a real catalyzer of activity. And I shouldn't say that. This was a quote I used in a recent podcast that others told me they loved, so I thought I would repeat it here. It's not about what the lab wants to do. It's about what the patient needs the lab to do. And by that, again, I mean that the patient is in many ways overwhelmed by all the information in the system, and they can be confused by jargon. Our lab results are not very patient friendly. That's a project by itself, how to move away from H's and L's and stars and all these strange lab names into a more patient friendly result. Is an area that we can respond to patient needs on, and we should. As you approach how you are going to interact with the system, you really should think about what are each stakeholder's key questions. So the patient's asking questions like, when should I have tests? What pre-test information should I know? When are my results available? What do the results mean? And what further information is needed, or what choices do I have to make? The clinicians, the nurses, the physicians, other people involved with the care of the patient are asking, what test should I order? Is the test process proceeding as I expected, error-free, in a timely fashion? What do the results mean? And is there guidance about next steps, whether there be follow-up testing or some other procedure, or move right to the treatment category, the treatment step? When you actually start trying to implement some of these strategies, you really need to remember a few. One is, try to make it multidisciplinary. If it's the lab doing it to the health system, it is not going to be nearly as successful as if it's the lab in partnership with the other stakeholders in the system. So having a multidisciplinary team not only will help ensure success, but it also helps ensure that things aren't being forgotten, the unintended consequences, the other factors that need to be considered. Everyone is bringing their expertise to the table. Making sure we always stay patient-centric. When we think about risk, it's not risk based on the turnaround time in the lab. It's not the risk of short fills. It's not those or other high-frequency errors that may have low outcome impact. It's really based on what matters for relative to patient harm or the ability to improve outcomes. As we think of the units of measure that we will use to see our impact, focusing on clinical indicators like length of stay, readmissions, antibiotic uses. Yes, you cannot isolate the lab's impact to all those things, but over time, you should be able to see inflections in trends or other things as a result of interventions you may have introduced. So it is still far better to show your impact on those indicators than to do something on the turnaround time after something hits the lab until it leaves the lab, because that has very little to do with what's going on. Whether it's 13 minutes or 60 minutes or 90 minutes has very little to do with a multi-day encounter with a patient. You should think about cost. Cost is a very real measure, but don't think of the lab costs first. Think of the system level cost. Actually, the patient is, what's the cost to the patient first? And then what's the cost to the health system? It may be that we have to spend more money in the lab to save money for the system. Running a test that's expensive and not reimbursed may help get someone onto the right treatment faster that shortens their length of stay. So focusing on cost at the patient level or system level is much more important than the department or laboratory level. Many of the initiatives you may want to will require IT support, and therefore making sure that the IT department is your partner is a very strategic importance. Many things have been studied, and often quality improvement in laboratory practices don't make it into the peer-reviewed literature, but do make it into meeting presentations, do make it into other gray literature. Definitely check broadly what's out there so you don't have to reinvent the wheel. And then communicate. Tell your story. Brag about your successes, especially the clinical successes, more so than the financial successes. I'm glad to say there is funding available. My organization awards seed grants to improve diagnosis, and virtually everything the clinical lab does has to do with diagnosis. These seed grants are a maximum of $50,000, and we will give out approximately 20 per year. We just completed our second round, and so it will open again for the third round, probably in October or November, but you can register at the SIDM website and be notified when it opens. If you look at information on the proposals, you'll see that we allocate against the big three: infection, vascular, and cancer. So 40% of the wards have big three impact. We look at disparities. We try to give out 40% of the awards having to do with disparities. And finally, anything else comes in is in the 20%. In my last couple of minutes, let me just quickly go through some of the winners. Now, if you'll see, I've bolded a few. Each of these represented a laboratory approach to reducing missed and delayed diagnosis. These descriptions, these winners, are all up on the SIDM website, so you can go into that website, see these things, and read a little bit more about what they're doing. Same thing with the rest of this cohort one. As you can see, there was one more: deploying a fail-safe notification tool for incomplete radiology tests. The same thing could be true for the clinical laboratory as well. We have not yet posted our cohort 2. We just had the judging meeting 10 days ago, so we're about to release the awards of that. But there's lots of information, and in the information online available with this on this platform, you will find a copy of the RFP and the frequently asked questions. And again, let me just wrap up in summary by saying that providing an accurate and timely explanation of the patient's problem is foundational to appropriate care, improve outcomes and reduce costs, and thus an attractive target for quality improvement. Most of the sources of diagnostic error occur outside of the clinical laboratory, but appropriate test results are a key enabler of accurate and timely diagnosis and a wonderful opportunity for the laboratory to get engaged with the broader health system in producing improved patient outcomes. So work in partnership, that can be instrumental to achieving these improved patient outcomes. Closing thought before we go to Q&A. I love these 3 quotes that were part of the Institute of Medicine's report of improving diagnosis. The delivery of healthcare has proceeded for decades with the blind spot, diagnostic errors. Most people will experience at least one diagnostic error in their lifetime, sometimes with devastating consequences. And improving the diagnostic process is not only possible, but it also represents a moral, professional, and public health imperative. Diagnostic error is the #1 patient safety issue that exists. With that, I'll stop and thank you very much for your time. If you want more information, you can write me. If you can also go to our website, sign up. We do not spam people. We do not sell products. You can certainly sign up here and receive our newsletters and other information about the initiatives we have. And with that, I'll turn it back to Colleen.
Thank you, Paul, for your excellent presentation. It looks like we have some great time left for Q&A, which is fantastic because we have several wonderful questions asked by the audience. If there is a question that you would like to ask now, please do use the Ask a Question box located on the left of your screen, and we will answer as many questions as we have time for. So to get started, our first question is, what is your opinion whether labs should report and disclose their own lab errors to other patient care teams? Or do we just keep this in it as a lab's internal deviation?
So I think the first question is it clinically relevant? If it will influence a patient's care, there should be no question. We have to, because that's what we're about, is patient outcomes. If it's, depends on what it is. If you fail a QC check and then you recalibrate and you go back and look through the results since the last calibration, you don't find anything clinically relevant, you all have procedures already how to do that, but do you have to notify the rest of the clinical team? Well, of course you have to follow your own procedures, but aside from that, I think the litmus test is there a potential clinical relevance, and if so, yes.
Thank you. Another question from the audience. Do we need new standards for diagnostic tests in order to assure a better performance? Please refer to antigen tests for SARS-CoV-2 and home testing.
So that's an interesting question I struggle with, because rapid tests certainly serve a function, and it goes back to the public's and the clinicians' understanding of the test performance. I frequently tell people that even if there's a false positive, if it's operating within manufacturer's specifications, it's not necessarily an error. It's just the best biological testing can do. And it's within its claims. The key issue is, do you understand the risk, and do you factor that in? These normal ranges, or the reference interval as it's now called, are not hard and fast. You can, just because of any variation in results, you can get results that are outside of the reference interval as a part of normal variation, even if you're a healthy person. And so there always has to be interpretation. Typically, a physician should be either rerunning the test, maybe running it on a different platform, looking for other concurrent clinical symptoms, history, physical findings, other things, and make a judgment call. But each of the tests, whether they be lower sensitivity, lower specificity, but very inexpensive and easily distributed to impoverished areas of the world, that could be a very valuable result. So it has to be, each setting requires its own consideration.
Thank you. Thanks, Paul. And that actually leads quite nicely into the next question here. Judgment. Clinical judgment is clearly a big opportunity to make a significant impact, particularly from a test interpretation perspective. How do you envision the clinical laboratory taking leadership role in reducing these errors?
You know, there's a lot of different tools. You can't shadow every physician and offer advice on every test order or test interpretation. But different people have tried different tools. So among other things, again, using things like reflex testing in order to let the laboratory potentially move forward down a diagnostic scheme based on earlier results instead of leaving it for the physician. Establishing guidelines about privileging, where certain tests can only be ordered by specialists, a gastroenterologist or someone like that, and a primary care physician maybe can only order it with a pathologist's approval, as another example. I've always loved the notion of departmental report cards, where you just show the ordering patterns of the whole emergency room relative to troponin. And you can see one physician is at 3 times the ordering rate of everyone else. Without even identifying the physicians by the lab, you can share that with the department. They can review it themselves. The history says they will normalize. The one who's over ordering will tend to order less over time. They'll figure out that they're an outlier. So there are a lot of different tools, and clinical decision support tools, software, is certainly available to help guide physicians in their ordering, and the lab can help select that, help implement it, help understand when to use it and when not to use it. So there's many different ways that the lab can really make something happen. I'm not hearing you, Colleen.
Apologies. Thanks, Paul. It sounds like depending on the clinical problem, the lab has potentially multiple roles in the solution. Another question is, what is your opinion on how to reduce same lab orders ordered by multiple physicians? We have so many pushbacks with the hard/soft stuff with ordering from the physicians group. We have a large number of manually combining and crediting multiple duplicate tests. So I think this question is related to reducing over-ordering and multiple ordering.
So I'm probably not as familiar as I could be in terms of the tools that are currently available. Personally, I have my annual physical coming up, and I am seeing my primary care doc who put tests in this weekend. I went and had them done, and a specialty doc that I see for a specific problem had put in an order as well. I noticed that the specialty doc ordered a BMP, a basic metabolic panel, while my primary care doc ordered a comprehensive metabolic panel. When I went there, and again, I'm the patient and probably a little more aware of these things than most patients, but I said, I don't want to pay for both. Just do the CMP, don't run the BMP. And when I talked to the technician, the phlebotomist, they said, don't worry, our system eliminates those duplicates automatically. And I know they run an Epic system. I don't know if it's in the LIS or in Epic or where, but it seems to me, it sounds like there are tools available for eliminating redundant tests, but I don't know enough about the details of those.
Thank you. Another question is, how can clinical laboratorians impact the cognitive failures of treating clinicians?
Well, that's sort of similar to the one that I think we already answered. It sounds like a variation of the same thing, and that is, again, looking for patterns where you believe, back in the days before troponin was so well accepted, you had other kinds of markers for MIs that were being ordered, and because of bundles or specific equipment bundles, some of those other tests were being ordered far beyond their usefulness. So clearly creating some kind of a formulary so that you can eliminate obsolete tests, using order sets, using some of the tools we've already talked about, such as the report cards. Identifying global patterns of what appears to be an overuse situation may lead to some in-service training, CME training for your clinicians. Looking at other metrics, what's the new metric? Medically, let's see, it has to do with the average negative or the average abnormal rate. I forget, mean average or mean abnormal result, something like that. And in the one study I read about, they were looking and they were used to seeing about 25% of the tests for this category of tests showing up as outside the reference interval. And so that's what they expected. If they saw 5%, they knew that it was probably being over-ordered. And so they could work with that physician, said all of your colleagues, this is similar to the report card, are getting about a 25%. You're seeing the same population in the emergency room, yet only 5% of your patients are showing up as actionable, clinically actionable. So maybe you're ordering in too many cases. How can we help you with that? That's one example.
Thank you. And I think we have time for one last question. In your estimate, how many health systems have a focus on reducing diagnostic error, and how many should?
So how many health systems are there? I used to use, there were 1,000 systems, 5,000 hospitals. Anyway, every one of them should. This is the #1 patient safety issue. It leads to the premature deaths, both inpatient and out, of over 300,000 patients a year. So there isn't a system anywhere that shouldn't. Our experience is that it's difficult. It's tough stuff. Diagnosis always has uncertainty. A disease looks different in every patient and at different times with the patient. And so this is not easy stuff. There aren't good operating measures of delayed diagnosis. So it's tough. We're trying to build that whole awareness and burning platform. And we've created this coalition to improve diagnosis, which you can read about at our site, that now has over 70 organizations in it, including the American College of Emergency Physicians, the AACC, COLA, ASCLS, to name a few labs, but Leapfrog, Joint Commission, the American Medical Colleges, AAMC. So all these specialties, all these patient safety organizations, all these health systems, Geisinger, Intermountain Healthcare, we're all working together to try to do something about this problem. And maybe your health system will join the coalition. That would be great. You can also write me about that if you're interested.
Thanks, Paul. And that's a great way to round out the end of this fantastic webinar. So I want to say thank you again for your time today and for all the important work you do related to reducing diagnostic and medical error. I would also like to thank LabRoots and, of course, Abbott for this webinar. And before we go, I'd like to thank the audience for joining us today and for their interesting and insightful questions. We do have several questions that require some follow-up, as there is a great deal of interest. So for those of you whose questions we did not have time to answer today, we will ensure that we send out a response via the contact information you provided at the time of registration.
Yep, I'll be glad to do that.
Fantastic. And this webinar can also be viewed on demand. And so LabRoots does alert you via email when it's available. And we encourage you all to share this via email with your colleagues who may have interest but unfortunately missed today's live event. So I will say thank you and take care.
Thanks. Bye-bye.